Hi, welcome to the How to Health podcast. I'm Dr. Lori Marvis, and today I'm so excited to introduce Dr. Mark Faries. How are you today?
I'm doing well, thank you.
Thank you. And I know he's busy, and so he's got some really exceptional, specialty is what you describe this as a health and exercise psychologist. And I think this is just so fascinating. Can you tell us a little bit about yourself and how you came to this and where you are?
I can, sure. I appreciate it. I appreciate you having me. And what a great idea for a podcast. And so I appreciate you inviting me to be a part of this today. So in short, I was going to be a coach originally out of undergrad. I did my student teaching and realized I don't want to get paid like $1 an hour, for all the time that they spend for what they get paid. But in short, I decided that it wasn't for me. And so I tell most people that I was stuck with a kinesiology degree because, to be honest, I didn't know what to do with that, which has benefited me a lot now that I work so much with students trying to figure things out. So long story short, the reasonable thing was to go into the fitness industry. And so early on, I was wired more toward athletes. This brought me from Texas A&M to California, Southern California, and I was training at that time an extremely large commercial fitness facility, one of the largest in the world at that time. And so I was working with athletes, and I got into fitness models. Long story short, how that happened. But in short, I was training these elite folks. Well, what happened was other women who were not fitness models would come up to me and ask, "Hey, I want to look like that. Can you help me?" And I was like, "Well, I can give it a shot." And so that's where I first started learning about the complexities of behavior change. It didn't take long for me to really lose interest in the athlete fitness model group. I became very quickly more and more interested with the complexities of helping these mainly ladies lose weight and control body image issues and look at emotional eating and stress and self-control and how they regulate behavior. And even though they want to, why don't they do it? And I don't know. I just became very, very intrigued with that. I took a job out in Atlanta and after that. And so I was actually dealing with a lot more trainers and becoming frustrated with the disconnect between really a standard sense of knowledge and prescription. So in other words, one trainer would say this and another trainer would say this. And I was like, well, which one is right? And how are we going to manage this? So I decided at that time, and actually I had a discussion with Dr. Jim Anesi, who was at that time from Rutgers. He is now with the Metro Atlanta YMCAs. And he was a very strong mentor for me to start thinking about the behavioral aspects in a way that I had never thought about it. For example, in my world of kinesiology and exercise science, it was all about, well, you train with the exact prescription that you need to get to the end goal. And so, for instance, if you want to get strength, then you choose a weight that's 85% of your maximum weight and of your 1 rep max, and do that. But then he would say, well, what if they don't like the way that feels and they leave? And I was like, well, results they want. So I was really in this weird situation where I couldn't quite figure out which way was right or wrong. Long story short, I decided to go back and get my master's degree in exercise physiology. That brought me back here to Texas and to Baylor University. And I had a phenomenal experience there. Well, during that time, I had many mentors, but Dr. Rafer Lutz in particular pulled me under his wing as an exercise and sports psychologist. And so he got me into this world of, hey, maybe again, you should consider the psychological aspects of behavior, because I quickly learned in my degree that I knew what to tell people. The prescription in my mind was not the difficult part. Yeah, there are specifics, but how in the world do we get people to do that prescription? And he was able to kind of pull me in and help me understand that. Long story short, you fast forward, I ended up meeting Dr. John Bartholomew through Dr. Lutz, who is at the University of Texas at Austin. And so that's where I went for my Ph.D. In behavioral health, behavioral medicine world. And I was really able to dedicate under his mentorship sort of an upside down way of thinking, or just out of the box, like start challenging common thought on how people initiate behavior, how people maintain it, and maybe what are some of the unanswered theoretical questions. What are some of the newer perspectives? Because, you know, and still to this day, I consider this, I really like theory and the theories that we have, but at the same time, are we done? Because if we are, then are we not applying those theories correctly? Or perhaps are there new perspectives that just have not been considered yet? Or maybe there's new theories that exist in other fields that need to be applied to health, medicine, physical activity, nutrition. And so that time for me was really, really good for me to start considering a wide range of topics and be pushed, especially from the research world. So then that led me to my first faculty job out at Stephen F. Austin State University in East Texas, which was phenomenal. And for 5 years there, I really spent a continuation of my research time from my dissertation looking at women, particularly in weight loss and emotions, motivation, and coping, and the emotional process of weight control, and how we can lose weight in a number of ways. You know, I always get the question, what's the most efficient way to lose weight? And I commonly say, don't eat or drink anything until you reach your weight goal. And then they would ask, well, is that healthy? And I was like, well, no. Could I die? Yes. But are those goals too, right? Are you wanting to be healthy and lose weight? Are you wanting to survive and lose weight? Are you wanting to be attractive and lose weight? Are you wanting to maintain your faith or your role in the family? Or right? And it started getting more and more complex as far as what was valued and why was that valued. And so we started asking questions in the lab. We could bring men and women in and scan them with body composition scans and give them their typical results, their weight or their body composition, and say, Ms. Jones, you weigh this much, your BMI is this, that puts you in the obesity classification. You have this many pounds of fat on your body, the typical, and we found very quickly that process is not benign, and it can create an array of emotional responses, an array of motivational responses, and how these women and men were going to cope with that information. And then we found that how many people avoid that sort of information and don't get cancer screenings because I don't want to know if I have cancer. There was some data to support that if they would go to the doctor and the doctor would say, hey, you need to lose some weight, and they would leave. And between that visit and their next visit, if they didn't lose, they would just change doctors because they didn't want to go back and listen to it. And so it was just a weird balance of, again, all these different emotions, motivations, and way that these women in particular were coping with the stress and distress of their weight. Not only their innate kind of nature perspectives on their bodies and fat and body image and craving high fat, high sugar food, but also the nurture aspect and societal influences in their family and work emphasis. And so we developed really some new theories of this, and did a lot of really neat research in looking at brain activity, subconscious brain activity. We did a lot of survey, a lot of qualitative, and that put me to the point where I am now, which is actually putting this perspective into play in a much larger scale. So currently I'm the state extension health specialist for Texas A&M AgriLife Extension. And so we are the extension agency for the entire state. And we have several initiatives that are kicking off to try to put this behavioral perspective into practice, because as most of your listeners probably know, in Texas, 8 of the 10 leading causes of death are preventable chronic diseases. And so with physical inactivity, poor diet, obesity, and smoking being the 4 leading factors of those risk factors, we are now having to target, like with the American College of Lifestyle Medicine, where I serve on the board, we are targeting those particular behaviors as the true causes of disease and disability across the US. But then we're back at our same problem, right? It's like we know what medicine to prescribe, but how in the world do we get people to take that? And so right now what we're doing is we're preparing to test some novel models at county levels across an entire state to see if we can make larger scale impact using this sort of psychological behavioral perspective, as opposed to the typical telling people what to do, but not necessarily helping them with the why and the how.
Wow, there's just so much I could unpack from that right now. Besides the fact that, you know, humans are complicated, and it's not as simple as writing a prescription, because there's even compliance issues with medications. So and you bring in the whole factor of lifestyle medicine, change what I've eaten for 50 years, change what I've been doing. You know, there's so much that comes with that. Their relationship with the physician, it's extremely
complicated. Well, what I say as an analogy real quick is if it's like giving someone a pill bottle that they have to twist the cap 30 minutes every day just to be able to take their medicine. And it's not an easy twist. They have to crank, their arm's going to be sore the next day. Like, when do I have time to do that? Why in the world would I want to do this? I'm only doing it because you're making me do it. I don't want to twist this cap 30 minutes every day. Right. But that's our physical activity prescription. Right. And so it's a big pill to swallow, so to speak, for a lot of our patients. And I get it. I understand it.
It's like parenting almost. At least that's how I've deemed family medicine. Wow. So this is fascinating. So please, can you tell me how you plan on implementing this on a county-wide level? I mean, who's going to be the ones implementing it? What is their qualifications? How are they interacting with people? Where are you getting these people? I mean, there's so much there. That's fascinating.
It is. It's clearly a cooperative effort. And so we are working on continually building those cooperative relationships. So the extension agency in Texas and in other states have county extension agents embedded in the counties across that particular state. So we have 254 counties in Texas, and we have qualified extension agents with master level degrees that facilitate the education at each of those counties, across each of those counties. And so we are transitioning into more of a health focus because of the chronic disease burden. And with that, we are continually, and we'll make sure that all of these agents, a lot of them already have health backgrounds and health promotion, health education, public health. But the ones who do not, we are getting our capability, so to speak, improved upon, so that we will have a foundation of knowledge and education for the basics. Because, again, to reiterate, the prescription, 7 to 13 fruits and vegetables per day servings, eat more plants, right? Eat food, whole food, mostly plants, not too much, mycopollen. Mm-hmm. And so there's that physical activity, 150 minutes a week of moderate intensity, shooting ideally for 60 minutes a day, a minimum of 5,000 steps per day, ideally 7,500 plus steps per day. If you can get 3,000 of your steps at 100 steps per minute, then you could be reaching some kind of more physically active exercise type prescriptions. And so we got the what down. And so what we are able to do is our agents are very good at education. I mean, that's what they do. They're in public education, and they're embedded in the counties. They live and breathe that county. They're a part of that county. And so they understand the cultural nuances. In Texas, as you know, Lubbock is quite different than Southeast Texas and Orange.
Oh, yeah.
Or down south, in Victoria or Corpus Christi or Brownsville. And so across the state, there are different viewpoints, there's different cultures, there are different beliefs. The way we speak is different. If you're picking up any Texas from me, that's Southeast Texas. But if we went out to Midland and up in Lubbock area, we would pick up a different Texas accent. And so terrain is different. And so the beauty of extension is our agents are embedded, and they breathe that county and the people there, and they're passionate about those people. And so step one for us is equipping them to help facilitate delivery, whatever programmatic efforts that we have. So we have some educational efforts in play We're going to create new ones. We work with our School of Public Health and Dr. Jay Maddock, who is he's the dean of the School of Public Health here at Texas A&M, and is an advocate to help us with the evaluation part to make sure that we are doing it in the right way and that we can evaluate our programs in a way that we can improve upon consistently every year. But also in each community and county, there are several other great efforts. We just had our first inaugural Lone Star Lifestyle Medicine meeting, which we brought together some leaders for a think tank across the entire state. And it was quite a wonderful meeting. And it had representation from healthcare practice to education research and even public health, but all wired to prevent, treat, and reverse disease with lifestyle. And so there are other efforts that are going on that we can coordinate with. And so I'll be going to the Food as Medicine Conference out at Midland next week. And we will be able to discuss all the great things that they do, which they're doing phenomenal things. There are school districts across the state that are doing phenomenal things. There are work sites that are doing phenomenal things. There are universities that are doing wonderful things. And so my job is to help build the foundation through extension, but then coordinate with what's already going on, see what gaps we can fill, and then accommodate educational efforts across every level. So in other words, instead of scatter shooting, like in this county, we do a random effort, or in this county, we do a random effort. Could we, using that social ecological model with individual, with interpersonal relationships, the community, institutional level working out, could we go in and do an educational effort at every single level at the same time and accommodate as many people as we can and reaching them the way they need it to be reached? We have efforts in schools. We got programmatic efforts for early childhood. We have faith-based program that we're going to run. We have work site-based. We have community-level programs. We have senior living specialists. And so we have the ability to accommodate every one of those levels. It's just a matter of coordinating that and measuring it in a way and evaluating it in a way to where we can see if we're making not only changes at the individual level, but across the county.
Wow. So are you using like a social network kind of model? I mean, where you can maybe see those people are here and they have the greatest influence. Are you bringing individual physicians and practices into that as well?
We will be. That's right. And so part of this Lone Star Lifestyle Medicine meeting is we want to develop the models and the education and the needs for physicians and healthcare providers. Because you had mentioned either right before we started this or right when we started about being able to do this in a way that's effective in the time constraints and the billing constraints and the knowledge constraints of healthcare practitioners. And so, right. And so I think the team effort is about the only way. You know, years ago, it was all about getting the physician or the practitioner and making them a psychologist, a physiologist, a behavioral expert. Is your house caving in? Are you okay?
Yeah, there's a thunderstorm out here. So
oh no, okay.
I'm in Southern Florida, so yeah.
Okay, well it's going to be humid tomorrow then, huh?
Yeah. A little bit. But you were saying
we've moved from that perhaps to a team effort, and so if the doc doesn't have but 10, 12 minutes, 5 minutes, and they're willing to triage the patient. So some physicians, correct, will take 30 minutes, an hour, 90 minutes with a patient because that's what they believe, that's what they want to do. Others are in a situation where they just can't practice that way. And so could all these exercise physiologists that are craving to take on patients and are passionate about taking on patients and helping them with the physical activity prescription, with different disease states, for example, or different disabilities, or we already kind of have that model with registered dietitians, but what about wellness coaches and their ability to pick this up, other health psychologists and their ability to pick our county agents who are just sitting there waiting and would love to have a relationship with the local healthcare providers to pass on patients and then work together as a team. So yeah, we have to balance those things in my opinion.
Yeah, I think you're exactly. I would love to have the team approach, but the reality is coming from, I've worked in various different settings. I was in the military. I was in a rural town in Colorado. I've been, I trained at Texas Tech, of course. I've been in a private setting. I guess the constraints are, one is the time. They come in, you're rushed to just focus on the medications, make sure they're taking it. Are they, do you go over your labs? And then they have these other complaints, and it's really crunch time. We don't have integrated medicine as far as having, just regular mental health counselors available. The cost, there's not enough of them. Health coaches would have been a luxury and all the places I was at. So I think there comes a point that it does come back to the physician, somehow being the leader in this movement, because that's where I've seen that we've just kind of fallen back, and then we complain about, well, why is this happening in medicine? Why don't we have these resources? Well, we haven't stood up and said, this is what we need, and enough is enough, to be the advocate for the patient. But instead of just complaining, physician burnout's at an all-time high, physician suicide. So, I think we as physicians need to stand up and say, this is what we need to take the best care of our patients, and, get away from just the complaining and the whining, and say, absolutely, demand it. We don't need all this administrative burden. Simplify it. Use some of that. I mean, when I look at graphs, is where physicians' numbers have grown ever so slightly over the last 50 years. Administration is just like off the charts. And so I didn't even know these county extension things existed. So where could a local physician maybe reach out to get help like that? I mean, who would they contact?
Yeah. All right. So within their state, they would look for the cooperative extension service. So it would be housed most likely in the land grant institution of that state. So clearly here, if they're in Texas, they can get in contact with me.
Okay. And I'll put your contact information.
Yeah, please do. But also within the particular state. Now, some extension services in a particular state may not have the capacity at this point, but that's another step for us, is to take what we're able to do in Texas with the leadership that we have and the direction that we have, the vision that we have in this arena, and to help other states as well. And so even if there's some providers who are outside Texas, feel free to let them get with me, because at the same time, I think we can develop some innovative ways, especially with online technology, that can be and facilitate something when there's nothing.
Right, absolutely. I think that's where online has been so significant as far as sharing a message of what is an actual healthy diet, like you described. Of course, I'm a big fan of the plant-based diet. It's what I've been using for like 6 years, but with patients, and had tremendous success. So I guess we could get to, so we will provide resources for someone to reach out to, maybe get more of a team effort to help see what's available in their county. I mean, the physicians may not even know what's available in their county. There may be private, church-based, faith-based resources. There's tons of different things that they may not know there. But I'm curious, because I read these 2 papers that you sent to me that you wrote, and I was like enthralled. It took me seriously 3 hours. I was like copying stuff down and thinking. Okay. I was like, it should have been a textbook, and it was condensed to 4 pages or whatever. And but could you give me just a rundown for these folks who haven't read this paper? I mean, there's some amazing stuff here. I really like how let's talk about the shorter one first, is the value-based lifestyle medicine. Because I think that has been key, how I've been successful, because I've been innately always interested in psychology and learning people's why. And I found that's a great way to parent as well. But what is that? What is value-based lifestyle medicine, and how could someone learn how to do that or begin to understand that process?
Yeah, so it is good. And, it's sort of like, I've noticed this with practitioners as well, sort of like coaches. They may not know the psychology behind it or the term for it, but because they care about people and they're really trying to help, and they build relationships and they love others, they tend to get it, and they figure out the value-based way of doing what they do, whether it's building, adults out of kids, or whether it's working with patients and lifestyle change. And so value-based lifestyle medicine is just that. It's not just about the prescription. It is about the why, the patient's why behind this. Now, evidence-based medicine is typically looked at with three prongs. You have the evidence, the research part, to make sure that we are up to date on why we were prescribing particular things, from drugs to lifestyle. So there's that. But there's also the clinician's experience that provides heavily, that sometimes the research hasn't caught up to yet, or has been looked at in a particular way, but the clinician just knows because they know. And that's the second prong. The third prong is the values of the patient. And so what value-based lifestyle medicine is trying to do is to reiterate that third prong, which can easily be dismissed because of the emphasis on evidence, which is correct, and the emphasis on, this is what I know because I'm the doctor, which is good. And so it's bringing the values of the patient to the forefront. Now, this could be individual values for that particular individual that could or may not be consistent with their culture, their upbringing, their other general values in life. And how can we incorporate those values into our prescriptions? So, for example, I could have two patients and give them the same physical activity prescription of 30 minutes a day, let's say, or 7,500 steps per day. But the reason why they would do it, or how I would relay that information to them, would differ because of the values that they hold. And so that means we got to understand what those values are and have some meaningful, accessible way to look at their values, and then have some basic knowledge and understanding of how to work around a basic prescription so that it accommodates those particular values that individual patient has.
So how do you suggest to either a person, for example, maybe they could even do some initial insight, work on themselves. How do we find what those values are? I mean, is there a tool that we can use somewhere online, some type of survey or questionnaire, so we can, get that tethered down quickly? Because I know when I have conversations with patients, especially when we start talking about the touchy-feely stuff and values, it can go in 1,000 directions. It can go on for an hour, which I enjoy, but at the same time, you still have time constraints. Where should they start to kind of understand what their values are with, what you're describing?
Yeah, so as far as resources, there are some things that I've seen over the years, but really nothing that I have come across that makes this very, very simple. I wish it was simpler than it is, and maybe I'll invent something and get rich that will simplify it down. But you mentioned early on in this of how complex humans are, and I don't know how much we can simplify. However, what we've been learning, and actually one of my graduate students, Alyssa Abro, is going to be looking for her thesis at this exact topic. And what we have found is that over the past few years, there is some basic categories, so to speak. Susan Folkman and Richard Lazarus did a study in, I think it was 1986, where they were looking at their transactional model of stress and coping. And they looked at marital stress. And they found that there were really two major things at stake. And so they were appraised that these things are being threatened right now, and that's why I'm stressed. And one of those was self-esteem, and the second was the well-being of the significant other. And so a lot of the marital stress was coming from one of those two things, specifically when they were threatened or appraised as, hey, these things are at stake. And so I read that years ago, and there really has been little done since then. And so we started looking at how could we, in practice, we were seeing that that's what was happening is certain things were at stake. And so if I get a pre-diabetes diagnosis, one, if nothing is at stake, then I should have no motivation to fix anything. Charles Carver and Michael Shire's theories of self-regulation and feedback models, there needs to be some perceived discrepancy from a standard to initiate emotional responses and motivation to reduce that discrepancy. And so if we told a patient that her second toe was, half an inch longer than average, she may not care. But if she's a foot model and her career's at jeopardy, Now all of a sudden she cares. Does that make sense? So
Right.
that her professional career is at stake because of that diagnosis. Or as we were learning with weight loss, well, I'll tell you, okay, so we had a weight loss program, and we had our clients would come through, and I would ask every single one, why did you join? And they would all give their particular reasons. Well, one individual who I knew, I asked her, okay, so why did you join? She said, look, Mark, I know I'm fat. I said, okay, but why did you join? She said, my husband doesn't cook well. He's a chef, but he cooks good but bad, if you know what I mean. I said, yeah. We drink too much wine. I'm not active. I'm lazy. She went on and on and on and listed out the reasons she wasn't doing, even though she knew what to do. And so she got done. I said, okay, but why did you join?
I love it. You're stacking your whys.
That's it. And so she said, my 7-year-old granddaughter asked me, Grandma, why are you so fat? And then she signed up. Now, we can't go around to all the grandkids in the world and get them to ask their grandparents particular questions to try to inspire motivation to get healthy. But that organic sort of discrepancy that came, but what was at stake with that individual? It was her role as a grandparent. And that was threatened in that particular situation. Now she is motivated, and she has since seen great success. And so with quitting smoking, with physical activity and diet and weight loss, more particular, what we've been looking at, we see that there are these particular things that have become at stake. And if you ask, you'll get very simple answers at first. But the classic analogy of peeling back the onion, trying to get to the core, as you continue to ask, you start to see what is meaningful for them. So I'll give you my categories that we've seen. Okay, so number one would be sex, is what I call it, which would be related to physical attractiveness, body image related goals. We learned that women in particular would do crazy things for attractiveness and weight loss. And I don't think that's a big shocker. But like with my blog, fitnesspudding.com, we take on a lot of those myths. Can my bones be fat? I'm actually about to post one, ping pong for weight loss. And so we hear a lot of things that squeeze or suction or whatever, and we think it's going to work or not. And people will go on crazy fad diets. They will get surgery. They will not eat. They will have disordered eating. They will have crazy, unhealthy views of themselves. They will attribute that strong motivation of image disturbance to other areas of their life, and now they're not a good person because they don't weigh a particular amount. And it's sad, but it shows us how strong those motivations are. And so not everybody agrees with me on this, and that's okay, but one aspect is to avoid that motivation and only target a second stake, which would be survival. And I agree, some people are inspired by survival, but what we dealt with college-age women, for example, with prevention was, hey, I need you to lift weights now so you're not osteoporotic when you're 60. And they're like, whatever, if it doesn't help me this weekend, then I may not care. And so the only thing motivating them perhaps was their body image or this category of sex, so to speak. In marriages, we've seen women that want to be attractive for their significant others. And so do I dismiss that and force them to exercise for their health? Or can I use that motivation and teach them how to do it well and healthy and have a healthy perspective of themselves and balance and not let those beliefs get out of control? And so, again, there's this different viewpoints on that, but we tend to find what thing is at stake and utilize that as best we can and direct it to healthy. So sex, survival, social status, we have found is a big motivator, and just keeping up with the Joneses, so to speak. Physical functioning, family, role in the family, professional world, which also could be related to social status, and then spirituality. And we have seen those become stronger and stronger. The spirituality we've been targeting a lot, me personally in my current research efforts, and it is very meaningful to me. But from a public health standpoint, there are a lot of people that make a lot of decisions, do's and don'ts, because of their faith, and rightfully so. Personally, I don't lie because of that. I don't cheat on my wife because of those. So why can't I eat healthy because of those and take care of this body that I've been blessed with? And there are a lot of people that share similar beliefs. Some do it for environmental values, and they're eating healthy because they believe that such actions will help the environment, but it's based on a value that they have. And if we can't assess what those values are, then it's going to be very hard and difficult to make the prescription relevant to that person, or to understand why patient X comes in and I give them an obesity diagnosis and suggest and prescribe weight loss, physical activity, and a plant-based diet for their health, and they don't change because health may not be their motivator right now. Something else might be at stake. And if I miss that or don't bring that up, then I may have missed an opportunity. So we're going to be working toward a quick measure to give to patients to help identify what their common motivators would be, their common values would be, so that the practitioner could then very quickly, within just a couple minutes span, speak to those particular values that they have.
I think you're right on track. I'll tell you, the one question that I found to be the most helpful is, if because of your diabetes or because of whatever their physical ailments, I was like, what are you missing out in life that you really want to? I mean, in 10 years, what are you going to regret that you weren't able to do because of this chronic disease or whatever it is, the diagnosis? And that seems to really get to the why, the multiple layered why, a little more quickly, because a lot of times they'll bring up tears. There's an emotional response. And I know when I hit that emotional response, those triggers, and listening for those triggers, you can take a lesson from marketing. How do you get people to buy things? You listen for those hot topics, those words that they're constantly using. I'm too fat, my pants are too tight, my husband doesn't find me attractive. Those, okay, attractiveness is going to be the case. And let's build some confidence there and speak positive words, right? Those positive reinforcement words of you're going to feel attractive to yourself, so you can go in confidence and share that with your daughter, who may also have these same self-body images. So those are the things, just reframing it. But I think you're right on track. I think I'm really excited to see what you guys come up with her research and everything.
That's right. And I think you're right on as well with, here's the difficult part, is odds are if you do tap into the why, there will be an emotional response. And as we've seen in those articles, and what we do know and what we've even found, is that certain emotions are going to be tied to less motivation. And so if they're despondent or depressed or sad, the odds are when they leave the office, they're not going to do much, if anything. And so I can't let them leave unless they're in some emotional state that is going to be productive for motivation. Theoretically, you have frustration and anger, even though they're negative emotions, tend to be tied generally higher levels of effort and motivation. Then we can just steer them in the right direction. Eagerness is awesome when it comes to motivation. If they get real happy, they might coast and kind of pull back. I lost my 10 pounds. I'm gonna go have margaritas and kind of fall off the wagon. But
short follow-up cures that.
Short follow, that's right. But also it taps into, how do we view the situation? A colleague and good friend of mine, Dr. Eric Janegi, who I would also recommend for everybody to get in contact with. When you talked about physician burnout and suicide, he has taken a model working with elite athletes, a psychological model, and now is applying it to physicians and healthcare providers. It's completely novel. It's incredible. And so you need to get him on actually to this pod. I'll connect you to.
Please, that would be amazing.
He can take on the challenges that we have when a patient is upset. What paradigm do they view this from? Is this a challenge? Is this a threat? Is this being viewed in more of a mindful way, where I'm non-judgmental, or am I attributing this situation to me and my shortcomings? Am I experiencing shame, or am I experiencing guilt? And what are the potential effects of either one of those? So that's where it gets even more complex, is when you do have particular emotional responses that are tied to either more or less motivation, but then the attribution, where are those feelings being attributed to? Is it, I'm feeling bad because you, the doctor, made me feel bad, or is it because, I'm a bad person? And how we navigate and the paradigm and the lens that we see that entire experience from, even something seemingly benign as again, an overweight diagnosis or a pre-diabetes diagnosis, it can become so routine for the practitioner that we lose sight of the milieu of psychological responses in that particular patient. And that would be, you brought that up kind of roundabout way, but I just want to emphasize that it's important.
You're exactly right. And I've always made a point of ending every appointment, if possible. For the most part, they are with giving hope, because I think hope is the one thing that we miss. We don't understand that it's very powerful. So I like to get the patient to see that there is the need and they have that emotional response. And then I'm able to bridge it to, well, there's these lifestyle medicine prescriptions I can provide for you. And then determine what, and you also write about capacity and what they're able to do, and say, okay, what can you do? Make it a little challenging, but not so easy that they just like, oh, I could do it tomorrow or whatever. And then I always make them feel accountable to me as the practitioner, saying, I'm here investing my time and effort in talking to you about this because I care about your health. I said, you should care about your health more than I do. So what is it that we can do to make that a point? And I've even made pinky promises with patients. I'm telling you, I seriously have done this in the patient room with adults. And I think that speaks volumes of what we need to learn to do as practitioners, is just this human connection and sharing, the journey together. And you're right. Yeah. We just become so used to, here's your prescription, get out the door. I just need your numbers to be where they need to be, so I meet my metrics. To no, this is a relationship. These people are coming to you because you're maybe the one person that they speak to all day, and you could change their lives.
You're exactly right. Yeah, I didn't say that, by the way.
No, my iPhone went off. I don't even know why I did that.
I didn't want the listeners to think that I was talking about how amazing I am. Yeah. So,
gosh.
So that brings up another good point too. Is that one? What would motivate a practitioner to even do that? You know what I mean? Like, you do it, and there are many others that do it. And a lot of people probably listening to this are like, they're buying in because they believe it. But what about all the other practitioners that are caught up in that kind of daily grind and that system? And we need to help them find their passion again. In the med school, typically third year, right?
Yes.
The students during their clinicals tend to lose empathy very drastically. And so it starts there. So maybe we need to start at undergrad education and medical education. That's why I love the American College of Lifestyle Medicine. Have you've been to the conference?
Yes, actually. And I'm taking their certification in October.
All right, good. Tucson. So I'll see you in Tucson then.
Oh, perfect.
Is you get around that many people who are that passionate. It's a wonderful, wonderful experience. And I highly recommend everybody going, if purely for that, not the knowledge that you would gain, but just to be around like-minded people. Well, I think we have avenues to encourage physicians to maybe find that their own why and why they even got into this in the first place. And clearly some get into it for the money and to have a second or third house, and that is what it is. But I think a lot got into it for the same reason that you're doing it now. They just need to reconnect. And I think we can have initiatives to help them reconnect. And like Dr. Janegi, who I mentioned earlier, he's helping practitioners do that. But a second thing it brings up too is hope. I agree. And basic human nature, we tend to be motivated by either fear or hope. And that's the way infomercials work as well. And so how do we inspire the hope? But then here's the other catch. So let's say I give them hope with an exercise prescription, okay, or fruit and vegetables. But then I tell them, I give them the prescription and not the roadmap, so to speak, of how to engage that and how to view that and how to ease into that. And they go exercise one day and they're sore. And all of a sudden they take that soreness as physical debility. And now I've eliminated all hope, or a lot of it, because of the way they feel or they're interpreting that exercise, which they haven't done in the years, if ever. And so how do you prescribe it and give hope, but then at the same time prescribe it in a particular way that maintains confidence, that maintains their outcome expectations, their belief that they can do it, their attitude about the behavior. Outcome expectations are highly influenced by past failures or successes. And people will say all the time, well, I've tried to lose weight 10 times before and I failed each time. But at the same time, you've actually succeeded 9 times. So we just have to figure out ways to help maintain the success that you've already had. So quit viewing it as a failure and reframing, as you mentioned earlier, in a way that's going to be productive. Dr. Janagi and I are actually working on a process to ease this called Eat, Move, React. And we're developing an app that practitioners can just give to the patients, where it assesses their confidence. All these psychological things that we know in the evidence predict behavioral adoption. And it produces a very, very simple report that the physician can glance at and see the 1, 2, maybe 3 things that they're deficient. Let's say confidence. So let's say they are 20 out of 100% confident they could get 30 minutes of physical activity 5 days a week next week. Well, then it would be wrong for that physician to say your prescription is 150 minutes because they don't have any confidence it's not going to work. But that physician could then spend just a minute or two saying, well, what would you be confident? Would it be 3 days a week for 15 minutes? Oh, yeah, that's a 80% out of 100. Well, then that's your prescription, and I'll see you in a few weeks, and we'll check in how that goes. So it's going to help with maintaining hope via the prescription, which is dictated by some of these basic psychological behavioral principles that every practitioner should know.
That's fascinating. I did work comp for a little bit, and we used something similar to measure how the patient was doing emotionally, physically, as far as their healing process and their injury. Mm-hmm. And it worked really well because it took the subjective component out of me trying to figure out what this patient's doing.
Right. Yeah.
And made it very objective. And the patient was telling me, and I use that also, like, you're telling me this is what you can do. Yeah. And then if there's some discrepancy there, or incongruency there, we can talk about it. So I thought it was a very powerful tool, and I think that's amazing. So you would just like have it on a tablet in their office, and they would just give it to them and say, "Hey, here's this."
Yeah, in the waiting room. That's right.
Oh wow! Or maybe even a patient portal, they could email it to them and say, "Have this done before your appointment."
That's it. You betcha.
Oh wow, that is incredible.
Yeah, it would simplify things down a lot, and it would really help take the load off the practitioner. Which it's like you said, time is a huge barrier. And knowledge is a huge barrier. I don't know how to handle behavioral beliefs or subjective norms or self-determined versus other determined motivations or all the things that we know are so crucial. How do I build autonomy? How do I build self-efficacy? What is vicarious experience or mastery experience? There's a lot of concepts, again, that are clearly linked to behavioral adoption, but unfortunately, we don't get that in med school, and we don't get that capacity. And so we have to, that's a part of my job, is to help build that. And so we have some other efforts that will hopefully be coming out to help build that knowledge. Stay tuned. I have a website that'll come out hopefully in the fall. It's called changemaintain.com. And it's just going to be a continuing education site. And so you just go there and get all of this continuing education, and we'll work towards CME to make it reasonable. Again, you got to tap into the motivation to do it. Besides just the want to, it'd be nice to get those credits. And so, yeah, any clever ways that we can come up with to build the capacity of the practitioner subsequently, which is going to help patient behavioral adoption.
I think you're exactly right on, because I've had multiple physicians. So as I've come across, on social media, I'm pretty active. There are multiple doctors reaching out to me weekly now. How do you do this? I want to do this. It would just be so much more rewarding than doing my regular job. I think you're definitely tapping into a niche that will be very friendly to it and excited.
Well, and you are too. And all it does is reiterate that the work that you're doing and others, that there are a lot of people craving this. And would love to get to a model. And so what are their barriers, and how can we help them transition from their current practice model to one that does get them back to where they originally started this journey, And I have personally seen, as you have too, the fulfillment in those who have made this transition.
Mm-hmm.
And it's a beautiful thing to see.
Yeah, I tell people, it's a dopamine high to help people. You just continually, and now that if you can help the helpers, help the physicians,
Yeah,
I've seen,
right.
since my daughter started medical school, and I have 3 children, and my youngest wants to start medical school. He starts college next week, or next few weeks. I'm even more concerned and motivated because these kids are going to be entering a whole different world with more time constraints, less money, more chronic disease. We got to set some tools in place, and I love this. I could keep talking for you forever. I really appreciate your time. It's already 50 minutes in.
We sure are.
I
All
know
right, well,
you
you
have
better
time.
get to your questions then.
Yeah, well, no, I know you have you're short on time, and maybe we could set up a second interview. That would be really amazing. Cool. And then but I always like to end the podcast with acknowledgement and saying thank you for everything that you've done, because I'm going to cut it short here in a second because I want to get Dr. Zanagi's. I'm assuming he's Ph.D. Dr. Zanagi, or is MD?
That's correct.
Okay, cool.
Ph.D. That's correct.
Cool, because I want to get his information. I know you have a meeting, so but just acknowledge it and say thank you for everything you're doing. I mean, this is fascinating. I think it's just an important part of making our human existence better and just healing. And this is some really good stuff here. I really appreciate you so much. Thank you.
Well, I sure appreciate it too, Laura, and I look forward to coming back for the next visit.
Cool, very cool. And thanks again, everyone, for listening.